Hello, welcome back. We got a patient walked in as an emergency. So she's had a filling for the last 60 years. She's 91 years old, had a filling for about 60 years, and it fell out. Hadn't been to the dentist in a while, sat down, took an image, and this is what showed up in the chair. At number 4. So you can see the hole in the tooth. What you can't really appreciate is the extent of the decay that allowed that filling to fall out. So typically when a patient comes in and a filling is just straight up just out of the tooth, if it's an amalgam or a silver filling, one of those metal fillings they used to do back in the day, some people still do it, but typically it fell out and failed because there was a lot of decay in the tooth. And that was certainly this situation. So we opened it up. We removed the decay. We confirmed with Carrie's indicator paste that I had gotten all of the decay, and then I left as much tooth structure as I could to try and prevent this tooth from fracturing underneath the crown. There are few things worse than restoring a crown that ends up failing due to the tooth just fracturing a couple months later. So I have learned to leave as much of that tooth structure as possible on cases where fracture is a concern. So here's our prep. You can see, really thin margin there, buccal and lingual. It's probably going to cause us to struggle a little bit on our contours. So she may end up with a little bit of extra bulk on the buccal or lingual. But that is preferable or better than allowing that tooth to fracture. We don't want to take away too much tooth and not have any strength left. Okay. Almost done with our margin here. Pretty tough crown prep, mostly because, as we get older patients in the chair, a lot of times they're pretty shaky. And so she was shaking. I had to have a good finger rest, but maybe not the best prep I've ever done, but it should be good enough for what we need. It should allow us to restore. Okay. Let's also bring this out. So just touch. Okay, and that is our margin. Our insertion axis. It's going to be tough not to get any undercuts here. As I said earlier, buccal lingual dimensions are very parallel. There's not a ton of restorative space, but I did like the fact that we were able to save, more tooth structure by keeping those walls pretty parallel. We may pay for it in a minute with our contour, though. We're about to find out. Let's see. Spacer is still 120 microns. We certainly want to bond to this on. Let's just jump straight into our proposal, see what it gives us. Now we are using zirconia here, so I only need, there's that bulging buccal wall there. I only need 0.6 millimeters circumferentially. But let's see what we can do. So FOCC, F is fissure height, that is adequate. O is occlusion. We are going to form remove, put on our lower arch, and use this remove tool to get rid of that green spot. Our occlusion is now dialed in. First C is contour. So this is where we're talking about that bulging buccal cusp. Let's see if we can't put this thing on Ozempic and bring it in just a touch. Okay, that looks better. Now we've got this minimal thickness issue here. Let's just bring that out slightly. Okay. And then what I can do is I can contour that some with post-mill processing. But let me see if I can just smooth it a touch. Okay. I don't love it, but it's better than letting that tooth fracture. So it's going to work for what we need. Using our form add tool here around the margin. Satisfying that amount of thickness there. I can contour that some. Make sure it's nice and smooth before I finish. Okay. You can see that I left my margin on enamel. I did not choose to drop it all the way down to cementum. Imagine prepping down that far and losing more tooth structure. Like it's at a certain point, it's just not worth it. So typically I tell my 90-year-old patients that my goals for you are to chew your food, not have an infection, not be in pain. Those are my goals. I think we can achieve them here. Let's check our articulator. Just a little bit of an interference. We're going to get rid of that. We don't want any kind of lateral force encouraging this tooth to snap at the gum line. That would not be good for anyone. So we'll just remove those interferences. Check our pre-op. Looks pretty close to how it was. Like I said, a little, turn this off so we can see it. A little bit wider in that buccal dimension, but the trade-off was we got to keep more tooth structure, and so this tooth is less likely to fracture. I'm going to call that a win. And our patient keeps her tooth. Life goes on. Thanks for watching.